Welcome, everyone. Can you hear me? Thank you all for coming out tonight to the fourth annual H. Ralph Schumacher Lecture. And it is my pleasure this evening to announce tonight's speaker, Dr. Donald Goldsmith. And I'd also like to thank our pharma support. They're listed on one of the slides going through. Thank you very much. Dr. Goldsmith is a professor of pediatrics at Drexel University College of Medicine and chief of rheumatology at St. Christopher's Hospital for Children. Dr. Goldsmith graduated from the University of Vermont College of Medicine, where he was elected to AOA. He completed a pediatrics residency at St. Christopher's Hospital and a fellowship in rheumatology at Temple University School of Medicine, St. Christopher's Hospital for Children. Dr. Goldsmith has had an extraordinary career as a pediatric rheumatologist, having served as faculty at several of the university hospitals in the Delaware Valley. He has many academic awards and achievements. In 2012, he was designated as a Master of the American College of Rheumatology. Currently, Dr. Goldsmith is the president of the medical staff at St. Christopher's. He is on the Task Force Arthritis Foundation of Southeastern Pennsylvania. He is the medical director of the Children's Arthritis Network of Pennsylvania. He serves on the editorial board of the Journal of Clinical Rheumatology. Dr. Goldsmith has published extensively, including over 50 articles by my count on his extensive CV. Dr. Goldsmith's clinical interests include the effects of physical conditioning on functional health assessment in children with rheumatic diseases, therapeutic agents for the treatment of juvenile arthritis, uveitis in children, Lyme disease, undifferentiated rheumatic disorders of childhood, and neonatal onset multisystem inflammatory disease, or NOMID. Welcome Dr. Goldsmith this evening, who will speak on the expanding mosaic of autoinflammatory diseases.
Clicker. Okay. Thank you for that very nice introduction, much too expansive. It's a real privilege to be able to present the Ralph Schumacher Lecture. Like many of us in Philadelphia, we all grew to know and love Ralph. I first engaged him when I was asking around as to who might help me work out a patient who we were seeing, a young woman with sickle cell disease who had developed polyarthritis. And of course, who else but Dr. Schumacher would be able to point the way, and of course he not where do I need to point it?
Upside down. There you go. There you go.
Okay. Upside down. Okay. Well, there's Ralph at his laboratory with his precious electron microscope. There he was welcoming, curious, understanding with my queries. And over the years, we engaged in several other collaborations. As a gentleman and a collaborator, I guess the best way to say what Ralph did for you, he kept you on your game. To take a sports analogy, that's what he does. He questions in his own semi-challenging way, and just moves you forward. And it's always a pleasure to have any kind of interaction with Ralph. A little out of order, but anyway, Ralph, with all of his accolades, of course, traveled a bit. There he is with his very famous half smile in China, back, I believe, in the late 80s. And then, of course, his very famous backyard and garden which was written up many times in Philadelphia magazines and newspapers. And I think you can probably recognize a few people here. There's Fred right there. There's Barbara Ostroff. There's Joan. And it's a testimonial to all of the people in the room and in Philadelphia whose education he had a significant impact. You may not know, he was also a pretty darn fantastic athlete. He was inducted into the Ursinus College Hall of Fame in 1997 for basketball and tennis. I don't know if anybody played with him, but there he is shooting up a hoop when he was in Taiwan, actually setting up one of the first adult rheumatology sections in Taiwan. So I can just read something for you that he wrote in the Journal of Clinical Rheumatology. He wrote a nice piece called 1 Week in the Life of Your JCR Editor. And the opening sentence was, "I have a wonderful life that I would not exchange for any other." And I think it bespeaks who Ralph was and what he liked to do and what he enjoyed, and what a great colleague he was and is. Okay, so let's move to the substance of tonight's presentation. I've chosen to talk about the autoinflammatory diseases. I've been very fortunate to have a little role in their evolution and growth and nomenclature over the last many years. So I'm going to try to take you through a journey. We're going to skip back from decade to decade and show you how this field emerged, and then in the last part of the presentation talk about some of the newer autoinflammatory diseases that have been just recently recognized. So what was the start? Well, the start really was the discovery of the mutated gene in familial Mediterranean fever in 1997. As you know, when we go back 20, 30, 40 years ago, we always knew about this disorder, this funny inflammatory disorder that was periodic. It seemed to be inherited in a recessive manner, but we didn't know much more about it or where it fit as an inflammatory disorder. But when Dan Kastner was able to, along with another group, clone the gene and recognize it, it started an entire new facet of rheumatology and a whole new section in arthritis and rheumatism, which now has one for autoinflammatory disorders. It's been facilitated, of course, by tremendous advances in genetics, and particularly next generation sequencing, which has taken the place of Sanger sequencing, candidate gene, clonal expression. Now you can do things in jig time with both whole genome, but in particularly whole exome sequencing. And as these disorders have been delineated, we believe that they are primarily disorders of the innate immune system. The first responders rather than the second responders. You could consider the 70s, the 60s, 70s, and 80s T and B cell land, and within the last 10 to 15 years, so much more has occurred related to disorders of cytokines and signaling molecules that reside in the innate immune system rather than the adaptive immune system. Now, saying that, we all know that the immune system is still very pleiotropic, and the more we learn about this, these are probably going to merge a little bit, but I think it's very helpful to think about it in this way. Okay, so how did it get the name autoinflammatory? Well, it just was a natural thing with Mike McDermott and Dan Kastner after they wrote a paper, which I'll mention in a minute or two, that you really didn't have antibodies, so you really couldn't call it an autoimmune disorder. Didn't have autoreactive T cells, so you needed another name, and why not autoinflammatory? Keeps the self in, keeps the inflammatory in, but discards the fact that there are autoantibodies and autoreactive T cells as well as classic HLA associations. So this is the nomenclature. Now, I'll call sort of these 4 or 5 disorders the old wave autoinflammatory disorders that have been recognized and developed and studied over the last 12 to 15 years. And as you can see, we have familial Mediterranean fever, cryopyrin-associated periodic syndromes, of which there are three, HIDS, which is hypergammaglobulinemia D, and inflammatory disease, and then TRAPS, which is tumor necrosis receptor-associated periodic syndrome. So I'm going to spend a good bit of time on these. But let's go back to familial Mediterranean fever. There's just a little history of some of the papers that were written and presented, going way back to the early 1900s. And then the name benign paroxysmal peritonitis was the going nomenclature in the 30s, in the 40s. And then an Israeli paper finally came up with the nomenclature of familial Mediterranean fever in 1958. And that's what it was called after that, and continues to be called that. It occurs most frequently in certain ethnic groups, particularly Ashkenazi and Sephardic Jews, Arabs, Armenians, and Turkish populations. It has been seen in every population, but it's really quite prevalent, more prevalent in those groups. And the pattern initially seemed to be very closely and most likely a recessive disorder with a very high frequency in the affected population, sometimes up to 1 in 400 and 500. Here's what the clinical picture is. You're probably all familiar with it. A fever that is episodic, occurs every 12 to 72 hours, and occurring every 2 to 6 weeks, usually in a pretty recognizable pattern, but not always so. And then there's serositis. Most often is peritonitis, but you can see both pleuritis and pericarditis in a much lower frequency, of course. And then the third major criteria is this funny-looking rash on the ankle and the lower extremity, which looks like erysipelas, but on biopsy has primarily polymorphonuclear cells, of course, primarily seen in the innate immune reactivity. And its onset is usually during childhood and about 90% before age 20. And of course, the real morbidity, eventual morbidity of FMF is the development of amyloidosis if episodes are frequent and episodes continue to occur without abatement. And that's, of course, primarily renal. Here's just a few descriptors to re-emphasize that. The slides on the left showing the serositis, both peritonitis, pleuritis, and then a pericardial effusion. Synovial fluid with a lot of polymorphonuclear cells, the biopsy of the rash. And then there's an SAA scan, a renal scan, with somebody who has advanced amyloidosis as a result of continued inflammation with familial Mediterranean fever. So a lot of people started to think about this, and I have a picture of Dr. Dan Kastner, who's become a close friend, and I'd like to think a colleague as well. In 1989, when he was a fellow, a genetics rheumatology combined fellow at NIH, they were asked to see, or were seeing a patient of Armenian heritage who had a recurrent arthritis of the hip. And one of their Israeli visitors walked into the room and said, well, this is obviously FMF. And they treated the patient with colchicine and got better. And Dan had been thinking about doing something to try to clone this gene, and so he decided to go to Israel. He spent several months there in Israel collecting blood specimens in 1989. And then it took, as you can see, till 1997 to really find this gene. And that's the way it was back in those days with the sequencing technology. It took a long time after you found the chromosome to then find the gene. But they found it on chromosome 16 at the P13 position, and found that it encoded a protein called, which they named pyrin, and it's a member of the death domain family of proteins, which are heavily involved in cell signaling and apoptosis. And as is a thread of a lot of genetic discoveries over the last, over many years, there's often a race that's going on between different laboratories, and this first discovery was no different. And it was between a French consortium and an international consortium led by Dan. And they published pretty much around the same time, and so both given credit for the first recognition of the gene of FMF. Well, that certainly opened up a lot of interesting possibilities. Here's the structure. There's 10 exons, and there's a hot spot on exon 10, and then some activity on exon 2, but as we've learned, many of the mutations that can be present with these disorders may not necessarily be pathogenic and cause symptoms, and that's likely true with the E148Q mutation under most circumstances, but there are still variations. And these are missense mutations, so you can see what M694V stands for is a substitution of methionine for valine at the 694 codon. And you can see that it's primarily found in cells that reside primarily in the innate immune system category. And shortly thereafter, as their FMF activity ramped up, they began to identify patients who were referred to them from the United States, and you can see they were pretty representative of the usual ethnic populations, maybe a surprising number of Italian patients that we're seeing. However, it's in the Mediterranean basin, and it can be seen in any ethnic group, but predominantly in these. So as interest in FMF had grown, there was an international symposium every 3 or 4 years concerning FMF. And as I got more and more interested in these disorders, I found myself at the first one, which was actually in the United States. Most of them had been overseas, in Turkey and Israel and other places. And because there had been an expansion of these disorders, it was now called FMF and Beyond. And this was what was the 4th International Congress. And I happened to be sitting, having lunch with a good friend of mine, Kathleen O'Neill, rheumatologist now, pediatric rheumatologist in Indiana, and a lovely elderly gentleman walked by and asked if he could sit with us and have lunch. And I said, sure. And as it turns out, he introduced himself, and it was Dr. Stephen Goldfinger. Now, Stephen Goldfinger, not of 707 fame, but Stephen Goldfinger is a internist from Boston, and published the first paper on the treatment of FMF with colchicine. So when I heard his name, I said, oh my gosh, you are Dr. Goldfinger. And he was a completely, absolutely charming and really, really smart guy. So he described the clinical features in 5 patients in the New England Journal of Medicine, and there's the whole paper right there. That's it. It didn't go through the IRB, obviously. And he just took evidence from Maloista about what happened in gout with polymorphonuclear cells. And there had been some cholesterol crystals that had been seen in the inflammatory fluid of FMF. And so he said, well, if colchicine works for gout, maybe it'll work for FMF. And he was right. And he published it. And it's interesting, one of the papers he quotes here has Mordecai Pross as one of the authors, and Mordecai Pross was the gentleman who invited Dan Kastner over to Israel to study these patients and collect the samples. And of course, subsequent analyses in large studies have shown how effective colchicine is in this disorder, and that it not only can potentially inhibit the development of amyloidosis, it can actually reverse some amyloidosis once you started in a patient who hadn't been treated previously. I was so intrigued with Dr. Goldfinger, I kind of started to do a little research on him. And those of you who maybe done some training in Boston may or may not remember that he actually for many years published something called the Harvard Health Letter. And this was sort of the typical stuff that he would talk about. It seems to me as though the car guys in Boston, the show on NPR, probably took a lot of maybe this kind of data because he always loved to talk about the husband and wife issues, as the car guys do, a lot. So it was just a pleasure to meet Dr. Stephen Goldfinger and the amazing way in which colchicine was discovered to help FMF. All right, so that's FMF story. Let's talk about something else. Let's go back to the 1980s. And Williamson et al. In the Journal of Medicine, Quarterly Journal of Medicine in 1982 described a syndrome called familial Hibernian fever. Hibernian refers to Irish, so it was an Irish-Scottish family. It's with an episodic fever, not quite as characteristically frequent in terms of repetitiveness, and it was abdominal pain with peritonitis often seen, myalgias, and a very significant erythematous rash. In '97, as the NIH group, Dan and in this lab were getting revved up, they were asked to see an Irish patient there. And there was a man named Mike McDermott in the lab working with him, an Irishman, and he got very interested in this, and they were quickly able to look and see if they could establish where a gene was located. This seemed to also have, as I mentioned, probably an autosomal dominant inheritance rather than recessive inheritance. And they found several other families and looked further and further. And with what Dan says and Mike has said, a good bit of luck, they focused in on the TNF receptor early and found that the problem here was a defect in the gene that manufactures the TNF receptor, the TNF 55KDA receptor, and they were able to identify this and eventually called this disorder TRAPS. And there actually was one Philadelphia family that was in the original cohort, a patient of Dr. Balu Athreya's, who was sent down to NIH for analysis. And so it's called TRAPS, for short for the TNF receptor associated periodic syndrome. This is what these patients look like. There's a periorbital edema, some conjunctival injection. There's fasciitis. It looks like myositis sometimes on the MRI, but it's really fasciitis. It's an angry erythematous rash that seems to migrate from the superior part of the body down to the lower part of the body, so it goes from top to bottom. And they wrote it up and reported it very quickly in 1999, so up to 1999. And in this paper, that the term autoinflammatory disease was coined and so it was the second kind of gene cloning of a disorder in this category. And this is the paper in which they title it as such. Another picture of the cutaneous manifestations almost looks a little bit like erythema migrans, doesn't it? But it's much angrier, it's much redder, it may not show up quite as well in that picture. And here's sort of a clinical quick summary of what TRAPS is. And these attacks are much more irregular. You may only have 3 or 4 attacks a year, or 2 or 3 attacks, and they may last for 1 to 2 to 3 weeks. So we've all seen patients like this who puzzle us, and some of these certainly eventually fit into this category. There is no great, even though it was described as familial Hibernian fever, there is no great ethnic predilection. It's found equally in all ethnic groups. These patients can develop renal amyloidosis. The onset is most often in childhood, but it's very often not diagnosed until adulthood because it's not very characteristic. And if you're only having 2 or 3 or 4 episodes a year, you surely may not recognize that as a chronic disorder. And it was quickly realized that colchicine was not effective, whereas you could suppress an episode with corticosteroids. And because TNF is involved, etanercept was used initially. The thought for the pathogenesis of this was that originally it was related to receptor shedding defect. So the receptor hung on there, and if you poured some inhibitor in, you could diminish the inflammatory cascade. These days, most patients would initially be treated with interleukin-1 therapy. Okay, so those are two, TRAPS and FMF. And let's go back to the 1970s. So we're back in Denver, Colorado, where Alan Wander and Michael Kirkpatrick, who were very famous early allergy and immunology folks, were studying patients who had cold urticaria. Now, we all remember that there are different kinds of physical urticarias, pressure urticaria, temperature urticaria, vibratory urticaria, and then there was cold urticaria. And it seemed as though they had recognized a group who had cold urticaria, but they were a little different in that it seemed to run in families, and it wasn't necessarily related to direct cold exposure to the skin. It was ambient cold exposure. And they developed lesions which looked like hives, but on biopsy they really weren't hives. They were more neutrophils rather than mast cells and other cells which would be more characteristic of typical hives. And the patients felt poorly during these episodes, and they had elevated sed rates and C-reactive protein. So there was an inflammatory urticaria precipitated by cold. Pretty interesting and pretty peculiar. So time went by, and it was just in the literature as an entity. And Len Hoffman, who was one of Wanderer's colleagues, had a very clever and smart immunogeneticist rheumatologist son named Hal Hoffman, worked in San Diego. And he started to work on this very quickly and also ran into some really good luck and found mutations on chromosome 1 at position 44. And he renamed this familial cold autoinflammatory syndrome because he believed it probably was an autoinflammatory disorder. And wrote it up, as you can see, one of the early papers in 2001, shown on the bottom. And here's what this looks like, a quick clinical summary for you, which I've kind of mentioned most of the things. Fairly early onset, but could certainly be considered just a nonspecific rash of childhood. Occurs a few hours after cold exposure, lasts for about 12 hours. If you do a biopsy, again, it's not real urticaria. It's a negative ice cube challenge. That's how you make the diagnosis of regular cold urticaria. And seemed to be dominantly inherited, and no evidence of amyloidosis. There's one of the pictures of one of the early rashes, so it's a little more confluent as well in this particular instance. Called the gene CIAS1, which is cold-induced autoinflammatory syndrome. All right, so let's go back to the 1960s. And Muckles and Wells, British physicians, described a syndrome also in the Quarterly Journal of Medicine, which had its onset usually in the early years, but it could be in the adult years as well, where patients had fever, they felt poorly, a lot of malaise, eventually even developed some polyarthritis, even though it was transient, a lot of limb pains, and an urticarial-like rash. And they also had progressive sensorineural hearing loss, and many of them would develop amyloidosis. So they called that, in honor of their name, Muckle-Wells syndrome. And there that syndrome sat without much being able to be done for it for a long time. There's another picture showing you the rash and the hearing loss. Another picture of the rash. And this disorder seemed to interest some French geneticists, and they said, well, maybe it's similar to cold-induced urticaria. They looked carefully for the gene that might be mutated and found it, lo and behold, on the same loci as familial cold autoinflammatory disease. And it encodes a protein which they named cryopyrin, which has a pyrin domain, and so it's also similar in terms of where it sits and what its effects may be. with cytokine signaling. And these were two French papers back-to-back, basically in the same journal, locating. So the French were racing against themselves in this particular race. All right, so let's go back to me in 1980s in Philadelphia. And I was, I think when I was last year of my residency, I was asked to see a patient came into a clinic who had horrible developing arthritis, just awful looking arthritis. And there's a picture of almost the first day we saw her. Huge knee. The x-ray was absolutely like you've never seen anything like this before, complete destruction, a lot of cartilaginous deposition. What the heck was this or is this? The synovial fluid had 300,000 white cells and didn't grow anything. There was a rash. There were a number of other things. The child was also quite systemically ill. About a year and a half later, we encountered another patient who presented much earlier, had a little bit of macrocephaly, and as you can see, perhaps the wrist is a little funny looking, as is the elbow. And there's a more close-up picture of the wrist with some rash on the hands. And there's the early x-rays also showing a great deal of distortion and cartilaginous change and joint destruction. Similar inflammatory picture. We had another patient that came in shortly thereafter, and you can see the amazing patellar enlargement there, which was cartilaginous and bony as well. So we decided to write this up. I'm very academically kind of lazy, and so Sandy Hassink, who was the chief resident at St. Christopher's, I had just started on staff, said, hey, we got to write these kids up. There's something different. We did. We published it in Arthritis and Rheumatism, and I called it Neonatal Onset Multisystem Inflammatory Disease with the acronym NOMID. And this is the clinical spectrum. You can see there's also the name CINCA, and that was coined by Dr. Anne-Marie Prieur in France, who had also described this a few months after we did, and she was a little annoyed, actually, that the name NOMID was so cute. And it caught on that she wanted to name it CINCA. So to this day, in Europe, it's primarily called CINCA, and in the United States, it's called NOMID. And if you see any European papers, it'll be called CINCA. And there's just some more pictures showing you this horrible arthropathy. But we began to notice that there were many other features of this disorder. It was a disorder that had protean manifestations. And there they are, terribly ill children, absolutely no response of note except to corticosteroids. They were growth retarded, several had poor development, severe bony deformities, and worsening auditory and ocular findings. And gradually more and more cases were recognized because we had described it early. I began to see a number of these children in consultation from various parts of the country. And for 15 or 20 years, we just saw these children. They were still pretty rare, maybe only about 30 or 35 had been described. And it was just a horrible disease with no help for these kids in sight. And by the way, the first two children that we described did die. I'll tell you about one of them in a minute, as a result of their ongoing disease. And that sort of summarizes it. So here's what happened in 2002, a while ago now. I knew of Dan Kastner, but I had never met him, and he knew that I had an interest in this disease. They were seeing a youngster at NIH who was sent to them as if they had systemic onset JIA, and that's what we all kind of thought, that this was a variant thereof, but sometimes worse. And they had thought that perhaps they could look for the gene, and they were aware of some French work being done, and the French work had sort of focused on the fact that maybe this disorder with this fever and rash had some similarity to familial cold autoinflammatory syndrome and Muckle-Wells syndrome. So rather quickly, and those of you who know me in the room know I don't move quickly. Ralph would attest to that for my late reviews, and then Joan would agree. So would my wife. We rather quickly collected specimens. I was taking care of a few kids, one from Syracuse, one from Dubois, Pennsylvania, and we got these specimens to NIH. They looked for this gene as quickly as they could. They found it in about 2/3 of the patients. It was the same mutation, or the same protein, different mutations, and we went to a meeting at NIH. And rather quickly a draft came back to write. That's how I felt, because I don't move very fast. Unfortunately, this child, who I mentioned earlier, actually died about a week and a half after we sent her serum down to NIH. That was her in the intensive care unit getting dialyzed, and you could see how compromised she was. It was just a very, very sad situation. We got the draft back to Dan Kastner on May 19th, 2002, and unfortunately, 5 days later, the French published it online in the American Journal of Human Genetics, in which they also recognized that the gene was the same gene as those two disorders, different mutations. So we decided to just present it as a late-breaking abstract at the ACR meeting in 2002, and then published it in A&R in complete form in December 2002. And so here's just a representation of what this disorder is. It's a continuum of diseases, the one on the left being obviously very mild, and the one on the right being very, very severe, but the same cryopyrin mutation, cryopyrin proteins being the mutated protein, but just with more severe clinical characteristics based on which mutation you have. And you can see the mutations are on the top. Most all, again, common missense mutations, where one is one substitution of one amino acid for another. And so it's a spectrum of disease. Now, these are all new old diseases, meaning they've been around, but we're just recognizing them now. And Dr. Prieur found this picture in the French literature from the 1850s. And this probably represents the first clinical picture of Nomad syndrome. You know, who knows, but it certainly looks very familiar with this incredible cartilaginous and epiphyseal enlargement. Now, probably it was great to publish that paper, but what really I think was landmark about this paper was that we included studies of cytokines and interleukins, and in particular being concerned about interleukin-1. And as you look on the left there, you can see this is patient and control with an untreated monocytes. And this is a Western blot assay. You can see the patient untreated. There's an enormous interleukin-1 signature. Then with stimulation with lipopolysaccharide, which preferentially induces interleukin-1, interleukin-6, and TNF, but in this case we were just looking for interleukin-1. That it again produced it, and it did, of course, in the control. Further analysis, this is the interleukin receptor antagonist. Interleukin-1 is such a strong cytokine that it's really the only cytokine that has a natural inhibitor. You cannot live if you've got too much interleukin-1. You will crash and burn rather quickly. And you can see that this being an assay for interleukin-1 receptor antagonist, the patient has much higher levels in an attempt to diminish the effect of the interleukin-1 activity. So that set the stage for, hey, we've got interleukin-1 being incredibly active in this disorder. Maybe the interleukin-1 receptor antagonist will help this disease. So, let's skip a slide there. So this is what was our research objectives for this clinical trial, which started at NIH fairly quickly after we published this paper. We got all of those patients back to come back that were willing to, and many of them did, to travel to the NIH every 3 or 4 weeks. And daily subcutaneous injections of anakinra were administered. Now here's the trial design. I think we pediatric rheumatologists are proud of a number of things, and one of them is this withdrawal design, which has been used with a lot of medications when we're testing these in pediatric patients, and it's an attempt to eliminate the time that pediatric patients are on placebo. So you start everybody on the medication, and then you have a selective withdrawal, and you watch the patients very carefully, and so that's what you see right there. 18 patients were, we had 25 ready to go in, and the first 18 patients were analyzed, and the results were dramatic. Dramatic. Here's pre-treatment, post-treatment, and a flare period, 3 days post-withdrawal, after, and then rather quickly you could reinstitute the medication, which was done. So after 18 patients, the trial was stopped because of its tremendous benefits, and we couldn't see doing it any longer. Here's another picture which shows some of the great response. You see the rash, you see some of the ocular involvement. This is pachymeningeal involvement pre and post treatment. And this is an MRI with, forget there was a different kind of tracer, but it's showing cochlear involvement, and that's before and after. As I mentioned, a lot of these kids have significant hearing loss, and so it was dramatically effective in all areas, and so these kids who had been incredibly ill, now many of them had had significant changes that were irreversible, but their life dramatically changed for the better after entering this trial. It was written up in New England Journal of Medicine in 2006 with anakinra markedly improving clinical and laboratory manifestations in all of these 18 patients with neonatal onset multi-system disease. And in similarity to FMF, which colchicine can reverse renal amyloidosis, some of the children did have some reversible hearing loss. Or some hearing loss which was able to be reversed with anakinra. So not only improving the clinical manifestations that were active, but also some of the consequences that had developed. So just a little bit about interleukin-1. You know, this was the original fever molecule, and when anakinra was introduced, unfortunately, it was introduced around the time that TNF agents occurred. It was introduced obviously as a treatment for rheumatoid arthritis. Of course, the TNF agents seemed to be more effective, and of course, you didn't have to give it an injection every day, which is what you have to do with anakinra. So it's a difficult drug to administer on a regular basis. But a little bit of the history. Just a mention of Charlie Dinarello. I don't know if anybody has ever heard him speak, but he really is the father of interleukin-1. He's just a real character, charming, and he started to work on this in the 70s and should get the Nobel Prize at some point for his work on interleukin-1. I mentioned earlier, what is anakinra? It is an interleukin-1 receptor antagonist, so our laboratory biologists caught up with cytokines and were able to develop these in the laboratory, and this was a landmark development. Again, the only real cytokine that has its own natural inhibitor present in the body, and it helps us stay alive. So when the pharmaceutical companies began to look into this and try to manufacture interleukin-1 receptor antagonists, the first thing that was looked at was sepsis. So there, you may not be aware of this, and before it was used for arthritis, it was thought it was going to be very successful for sepsis because they had identified that there were very high levels of interleukin-1 during sepsis, and there were a number of studies which seemed to show it was helpful, but then a definitive study in 1998 did not reach its endpoint, and so it was abandoned as being a treatment for sepsis. I'm not so sure it doesn't help sepsis, and it wouldn't surprise me if maybe there's another something in the works with some of the interleukin-1 agents. And this is one of the early studies which paved the way for its approval for rheumatoid arthritis. And and that's on the top bullet, and as you look down to the second bullet, anakinra was approved for rheumatoid arthritis in 2001, but as knowledge of the patients with CAPS, and CAPS, by the way, is now the synonym for all of those three syndromes. So rather than call them separately Muckle-Wells or NOMID, you can refer to them as the cryopanopathies or CAPS, cryopanopathy syndromes. And as you can see, there are now, and Kineret being the last one to be approved, and that's primarily because of the fact that they just didn't have the network to get the studies done earlier, and the other companies moved in more quickly. And interleukin-1 was approved for CAPS patients, as you can see, 2008, 2009, and then again in 2013. Okay, so let me then quickly move to another syndrome. And this was recognized initially with a child who was in the NICU in Newfoundland, in Canada, with a neonatal onset of a syndrome which kind of looked a bit like NOMID, except it had more skin pustulosis. And it started very, very early, and several of the children who were eventually recognized died rather quickly. And that's the clinical picture. There had been some early observations after you were able to clone and develop mice that didn't have interleukin receptor antagonists, knockout mice. And some of those mice had developed some sort of chronic inflammatory disease, in this case one resembling rheumatoid arthritis and another resembling arteritis. So those were known. And here's a picture of some of those infants who eventually were recognized. It's a great network for this, and so as soon as that one patient was recognized in Newfoundland, other families were beginning to be recognized, and sera gets sent to the centers. In this case, it was also at NIH, and you can see how the bony lesions resemble neonatal onset multisystem inflammatory disease, but there were more pustules and more significant skin manifestation and an awful lot of osseous changes, with some an osteolytic lesion right here. Osteolytic lesion right here, periosteal cloaking, and enlarged ribs. So this is a young child. And as it turns out, this is an autosomal recessive disorder. And what it is, it's a mutation. And so a mutation of a protein that's making, or a gene that's making the interleukin-1 receptor antagonist. So these patients have no interleukin receptor antagonist. So they have continued stimulation of interleukin-1, and obviously they are incredibly sick from birth. And life-saving treatment can ensue with, obviously, the treatment with anakinra, which is basically a replacement of the interleukin-1 receptor antagonist. And there's a picture of some of the families and their mutations. These were truncating mutations, and one mutation which a family from Puerto Rico, which there are a lot of patients in Philadelphia who come from this region of Puerto Rico, So we are waiting for one of these to happen. It was written up in the New England Journal in 2009 and called DIRA, deficiency of the interleukin receptor antagonist. So you can see an accumulating group of disorders now related to mutations which alter the structure of the signaling proteins in some way and lead to unfettered inflammation. I can't talk about this without recognizing a man named George Schopp, who you probably haven't heard of, but the father of the inflammasome from Switzerland. As you probably read about intrinsic or innate immunity, you realize that there's toll-like receptors which are induced by PAMPs, which are pathogen-associated molecular patterns, and DAMPs, which are damage-associated molecular patterns. You're all aware that interleukin-1 is being touted as a treatment for gout, and this is essentially the reason, because one of the DAMPs is uric acid, and gout will respond to interleukin-1 antagonist therapy. Obviously a whole lot more expensive than the other medications that are used. In trying to figure out what was wrong with some of these patients, by chance, mevalonic acid was noted to be elevated in the urine of one of these patients who had HIDS, and a rather quick search tried to identify where the gene was, and they found that it was the gene that encoded mevalonic kinase in the patients who had HIDS. So you have a periodic syndrome now, which is not related to an effector protein, essentially, of the intrinsic, the innate immunity, but you have one that's a mediator of cholesterol synthesis and another very important pathway. So how does this happen? Quite unusual. Here's the clinical picture of HIDS. It is much more recognizable because it starts very young, usually during the first 3 to 6 months of age, with an abrupt high fever. Lasts for 3 to 5 days, may be a 3 to 6 week interval, with arthralgias, maculopapular skin lesions, a lot of abdominal discomfort. So some of these children actually can seem to have almost inflammatory bowel disease, with some ulcers, aphthous ulcers and large lymph nodes, and some cervical lymphadenopathy. And here's some pictures which demonstrate lymphadenopathy, mucosal ulcers, and the characteristic rash. And as it turns out, mevalonic aciduria has complete absence of mevalonic kinase, and HIDS syndrome has incomplete absence of mevalonic kinase, up to probably about 10% of activity. So it's a continuum, and the patients all have the febrile episodes, but the patients who just have hyper IgG syndrome have enough to get them past all of the developmental delays. There are and have been a few patients with a little more of an amalgam, but basically you can define these separately. And here's the pathway. You probably can recognize that this is the pathway of cholesterol synthesis, and that's a hydroxymethylglutaro coenzyme A reductase, which essentially are statins. And so it was thought that perhaps statin, if mevalonic kinase or the mevalonic acid excess was the reason why inflammatory process proceeded, that statins might help. Well, as it turns out, they helped a little bit, but not very much. And there's the mevalonic kinase block. So as you see, you're going to have an excess of mevalonic acid, but you're also going to have a shortage of the intermediates down below. And as experiments have proceeded, it seems as though the real pathogenesis here is not excess mevalonic acid, it's the shortage of the intermediates. And there have been elegant laboratory studies in vitro which have shown that this does activate the NLRP3 inflammasome, which is your interleukin-1 machinery, essentially. Let me go back there. Yeah, I guess there's one more. So treatment of this, we'll talk about that in a minute. So a typical inflammatory disease, immunoglobulinemia D with periodic fever. and mevalonic aciduria. It's of interest that as people have continued to look for these mutations, some MKD mutations have also been seen in neonatal hepatitis and very early onset inflammatory bowel disease. And it may have some relationship to retinitis pigmentosa and then a serious psoriatic offshoot called DSAP. In terms of how you treat this disorder, of course it's different. There had been some, there was a paper in 2001 by Joost Frankel from the Netherlands talking about interleukin, urinary leukotriene E4 being elevated. And so at NIH I was able to participate in a study in which we looked at montelukast to see if the use of montelukast would be helpful with these patients. As it turns out, it was transiently helpful, and there were rather quick breakthroughs, so we did not think it was any sustained benefit. So current therapeutic interventions for HIDS, sometimes if it's mild, you can get away with NSAIDs or a short course of corticosteroids, and if the corticosteroid burden is not too high, that's all you may need. But because of some of the work showing that interleukin-1 activity seemed to be increased with this disorder, anakinra was a treatment that we attempted with a small group of patients, I think about 13 patients, and published that in Arthritis and Rheumatism, and that is one of the agents now that is used quite often for HIDS, along with some anti-TNF agent activity. But you also wonder if some sort of dietary manipulation might eventually help this. If you have a depletion of some of those mediators, you could just sit down and eat some of those with a hearty diet and perhaps decrease inflammation. And there are a bunch of Italian workers who are working on that process. All right, so let me move into the last 5 or 10 minutes. What was interesting as you go way back to the FMF story, it seemed it was going to be really simple. You know, you have the clinical syndrome, you do the genetics, and you get the right mutations. But like anything, it gets more complicated. And Seyza Ozen, who's one of our illustrious pediatric rheumatologists in Turkey, expert on many things, but particularly FMF, had noted that, hey, same mutations seem to cause less severe disease in individuals who grew up in a different country. And indeed, what she first studied was the patients with FMF mutations who lived in Germany had much less severe disease than those who lived in Turkey. And what could be responsible for that? I don't think we do know, but some of the speculation could be, hey, maybe it's the microbiome that's hot. Diet, types of infections, somehow a resetting of the immune system. And here's an absolutely fascinating paper that appeared in Nature a year and a half ago. Now, I didn't mention something called chronic multifocal osteomyelitis or chronic recurrent multifocal osteomyelitis, but it's a little bit of a hot disorder at the moment. And it is thought to be an autoinflammatory disease, probably a monogenic disorder. And there is an experimental mouse. One great thing with advancing genetic knowledge and techniques is that you can produce mice who lack or add whatever you want genetically. So let me try to walk you through this. So this is the CMO is the multifocal osteomyelitis, chronic. And the mutation in this experimental mouse is the PST-PIP2, or protein serine threonine interacting protein 2. WT refers to wild type, and LFD refers to a low-fat diet, and HFD refers to a high-fat diet. This is a mutated mouse. It's a knock-in mouse with the mutation. So the normal diet they feed this mouse is low fat, and as you can see, it develops this horrible osteomyelitis. And when they used a high-fat diet, it seemed to limit the expression of the disorder. And that's also seen on this graph on the bottom, which is called a poor pathology score, and you can see the score is much higher with the low-fat diet than the high-fat diet. Then they looked at the microbial flora of those mice that had imbibed a high-fat diet, found normal microbial flora, whereas the low-fat diet had more pro-inflammatory flora, particularly Prevotella, and a reduced lactobacillus species. They then did a fecal transplant on mice who were about to develop CMO, and found that the high-fat diet fecal transplant delayed development of bone changes, whereas exactly the opposite happened with fecal transplant from the low-fat diet. So it would seem as though the microbiome may be of interest also in autoinflammatory disorders at some point, and there's going to be a lot more work on this. Another thing that was recognized rather quickly is that the mutation story is not the whole thing, is that you can just have one mutation and have a clinical picture that is very compatible with familial Mediterranean fever. And you still really have to make this diagnosis clinically. And then several carriers who didn't have symptoms have been studied in mass, and they seem to be a little different. Maybe have a slightly elevated low level of acute phase reactants, and maybe develop excessive febrile episodes and more rheumatic diseases than patients who don't have the mutation. And no one knows quite sure why that is true. Lots of speculation, but it is an observation. The same thing is true with single MVP mutations. We looked at our population of HIDS patients at NIH and found that about 3/4 of them only have one mutation, and there really wasn't much difference, aside from maybe a little increased incidence of rash, slightly higher IgA and IgD levels, that the clinical spectrum was basically the same, only with one MVK mutation. So it seems like these are recessive disorders, but a little different. And just some of the possibilities. We all know about epigenetics, where you can change you can change the phenotype look without changing DNA sequencing, and so that probably some other mechanisms as to why this may happen. So this is just a post in our pediatric room listserv. We have a wonderful pediatric room listserv. About 500 people from all over the world are always participating. And here's a posting, so letting you know that this is really stuff that's just still going on. We're still wondering, hey, we've got this patient that's got some other mutations. Are they significant, or are they not significant? And there were, of course, 3 or 4 answers to this, I think reasonably accurate. And I think this patient eventually was treated with colchicine. And I'm not sure whether they got better or not, but I just thought I would show that to you. Okay, so that's the first wave of hereditary periodic syndromes. Let me just talk about, in the next 5 or 10 minutes, what's continuing to happen now. So more and more patients are being looked at who have things that you just don't know what they are. And because of whole exome sequencing, remember, whole exome sequencing is sequencing the DNA that makes proteins, not the whole genome. Remember, there's 30 billion base pairs with the whole genome and 3 million base pairs for protein synthesis. It represents about 1 to 2% of the genome, but it's where most of the mischief takes place. So with the use of whole exome sequencing, which can be done now for probably about $1,000, and within a few weeks, you can get analysis of these patients and see what kind of mutations they have, and try to figure out, if you've got a cluster of them that have similar symptoms, whether or not this is a recognized new autoinflammatory disorder. And there's just sort of a little partial list of some of the syndromes that have been described in the last year and a half, from 2010, several from 2014. And here's just 3 that I will quickly go over with you, because I think they have some applicability, probably a little more to the adult rheumatologist. because they may resemble polyarteritis nodosa or other vasculitic, undifferentiated vasculitic syndromes, and then most recent one representing something that's very similar to Behçet syndrome. So DADA2, Kendall syndrome, and A2 haploinsufficiency. So back in 2001, I had the opportunity to see for a second opinion a seriously ill child from northern New Jersey, who I followed along with that pediatric rheumatologist for a number of years. We did not really know what was wrong with this child. We couldn't place it in a specific category, but she had rash. She had developed CVAs with several incidents. She had significant libido, developmental delay, recurrent fever. And then, again, as a result of a cerebral accident, some ophthalmoplegia. We eventually wound up, because of the recurrent fever, sent her to NIH. Anakinra was tried, did not work. And then a whole exome sequencing was done on April 4/11/12, in conjunction with 3 or 4 other children who were also being seen, who seemed to fit in a similar category with recurrent strokes and libido and seemingly vascular syndrome. And it seems like they all carried an autosomal, what we thought autosomal heredity, with a mutation in the CECR1 region, which encodes adenosine deaminase 2. Now, you all know that adenosine deaminase 1 is the aberration in severe immunodeficiency, severe immunodeficiency. The way, that's a zebrafish, if you didn't recognize it. One of the ongoing issues is when a mutation is found, you have to also look at functional studies, because you could just have a mutation that has no absolute consequence to it. And one of the major ways in which these are studied now is with something called the zebrafish. That's a representation. It's a fish which embryo grows outside of the mother. It's transparent for the first several days, and it's very easily genetically manipulated, particularly with what they call morpholino technology, where you have a substitute RNA base. So here's some of the functional studies that were done on some of these patients. And you can see that the ADA level on the top graph is quite low for the patients and normal in pediatric controls. And then on the bottom, this is the zebrafish. The green is blood vessels, and here represents red blood cells after a morpholino directed against the genetic makeup. This is remember, a knock-in mouse, a knock-in fish. And you see there is cerebral hemorrhage there. That's the brain of the zebrafish. So that was amazing technology that was brought to bear to show a functional defect for this disorder. If you happen to be watching the nightly news on May 9th, 2013, it made the nightly news as one of a group of children who had strokes. And finally, an etiology has been found. This was a family that was a little bit more publicity conscious than we liked, but and it was written up in the New England Journal in 2014. Of interest, prior to this, when you're trying to find what's happening, you always find old papers that are probably describing what you're looking at. And this was a paper, an Israeli paper, Navkan Elkan, and there's a lot of Georgian immigrant Jews in Israel, and there had been a paper which described sort of a familial vasculitis back in 2000, and in a previous paper talking about Georgian ulcers, which were skin ulcers as a result of vasculitis. So in the same issue of the New England Journal, this paper occurred. And the way it happened was that it's very interesting, because this was a group who had kind of had these findings going on for a long time, and they were kind of about to publish and didn't realize that NIH was also on the lookout for this. But there was a visiting guy from Israel there one day when I happened to be there, and he heard the NIH group talking about this. He was a little agitated because the Israel group was about to publish, and they eventually got together, published it in the same journal, and was wound up to be great cooperation. So that's an Israeli paper. So when you see those in the New England Journal, there's 2 papers back to back describing Dada syndrome. So what's the functionality here? Well, adenosine 2 is different. It seems to have an effect on endothelial cells and M2 subset macrophages, with the end result that there's a vicious cycle of vasculopathy and inflammation. And it's not just children. Patients have been described with onset at many, many different ages. And here's a picture of some of the findings. That's from the original paper. Carol Barron, at the last meeting of the ACR, presented, there were about now 21 or 22 patients at NIH who were being followed with this syndrome. When she presented this paper, that we had 16. And it's, again, just updating what the syndrome consists of and what you may see. There is some, the strokes are primarily in the midbrain, lower brain, but you can see some in the cerebral hemispheres as well. And they expanded the clinical picture somewhat. And this particular group is more young patients. The Israelis had started to treat their patients with TNF agent, etanercept, and it seems to work brilliantly. And this is the case now with the patients at NIH. There have been no further strokes in any patient who has been treated with etanercept, which is pretty amazing, where they had the total accumulation of 40 strokes before that. Here's a paper that you may have seen that was just put out as a prelim paper for ACNR. It'll be published formally, I guess, in another 2 or 3 months. Another group describing their experience with DADA2. This mutation now is really hot, if you will. And there is a hotline down to NIH if you have a patient that you think you'd like to have tested, so you don't have to try to argue with LabCorp or whoever else you use to try to get whole exome sequencing to see if this mutation is there. And so this is the most recent paper. So there's now 4 or 5 series on DADA2 deficiency. And this is a picture of one of their patients in that, from that paper. We published a paper on a child who died, who had a terrible series of strokes and cerebral damage, and we're trying to get a path slides analyzed to see whether or not this was a mutation, a DADA2 mutation as well. Here's the next syndrome, Candle syndrome. It stands for chronic atypical neutrophilic dermatosis with lipodystrophy and elevated temperature. These acronyms are getting a little crazy, I'm sure, you realize now. Described in younger people, and here's the clinical features. Progressive lipodystrophy is one of them, as well as recurrent fevers in early age of onset, swollen eyelids. Certainly a global syndrome. With a characteristic histological picture, and it seems like this disorder is a mutation in the proteasome subunit beta type 8, which causes this syndrome. It was published in Arthritis and Rheumatism in 2012. Here's one of the children from NIH with Candle syndrome. And what are proteasomes? They're protein degradation systems that take care of our ubiquinated proteins as they're trying to be eliminated from the body. The protein is unable to do this in an efficient manner, and there's an inflammatory process that is set up. It has a high interferon signature, and early work with Rafaela Goldblatt-Mansky at NIH seems to indicate that anti-interferon medications such as JAK inhibitors are effective with this particular disorder. Again, these individuals are going to probably present during childhood, but you're going to see them as adults because many of them won't be diagnosed, or you're going to see them as patients who have graduated into adult medicine practices. And here's the last one. It's just very recent from Nature and Genetics, also from NIH. And it's a loss of function mutation in TNF-AIP, which is TNF alpha-induced protein 3, which leads to what's called A2 haploinsufficiency and causes an early onset inflammatory disease, autoinflammatory disease, which resembles Behçet syndrome. It encodes, as I said, encodes the A2 protein, which is usually a very functional negative inhibitor of the nuclear factor kappa beta system, which is intrinsic to cell signaling and DNA expression and transcription. So anything that interferes with NF kappa B signaling is going to have a profound effect on inflammatory disease. So a number of families have been gathered together, and this mutation has been found. It resembles Behçet's. I absolutely know that this is going to have some significant impact, and it's probably going to explain some of those peculiar patients if you wonder whether they have Behçet syndrome or not, but don't quite fit. And there's just some of the clinical data from that new paper just published in 2016. People are trying to classify autoinflammatory disorders as best they can. I hope it doesn't get as bad as the vasculitides, but we're probably working our way towards that pathway. Do you do clinical features? Do you do pathogenesis? And this is just some early attempts to do this. I think it makes sense to probably do pathogenesis rather than clinical features. And I think because we really do have functional reasons for these happening, we'll be able to do that as time passes. Those of you who are hopefully stimulated by this presentation and will be looking at some of your strange patients, where do you send where do you send stuff for genetic testing? Well, GeneDx is certainly the big one in Gaithersburg. These are all on websites. They have great websites that tell you how to do it. And then we started to use Prevention Genetics, also a firm in Wisconsin. It was advertised as being a little less expensive. These are difficult to get insurance approval for, but if you really try and persist, usually it can happen. And for those of you who are interested in just sort of looking at this a little bit more, there's a great website called InFevers. I'm sorry, I could not get the slide to cut off properly, but you just go online, look for InFevers. There's a list of all of the autoinflammatory disorders that have been proven functionally. You just click and press, and you can look for specific mutations, because you'll get a report back with the mutation. It'll give you a description, but you want to read it about yourself. And there's the current numbers. This is the ongoing. People are always calling in and adding mutations all the time. It's an absolutely fantastic website. It's part of the IFSID, which is the International Autoinflammatory Organization. And lastly, maybe this is what bedside rounds will look like in 2020. So thank you. I'm sorry I was a little over, but appreciate your attention.